woman, birth, death, infinity.
Good afternoon, and welcome to the Your Health radio and television program on the radio at AM 1240 KNRY, AMP Cable Television Channel 24, and on the web at www.ampmedia.org. Join our rotating host and their informative guests live every Monday afternoon at 4 o'clock. The purpose of the Your Health radio and television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
Welcome to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so happy you could join us. My first guest, the illustrious Dr. Michael Stuntz, general surgeon, abdominal surgeon, and one of your specialties is the hernia. Dr. Stuntz, thanks so much for being here. I certainly appreciate you coming on the program.
Oh, my pleasure.
Well, Dr. Stuntz, hernias are very common, of course, and I think there's a lot of misconceptions about hernias. And hernias can occur all over the body. Can we start out by trying to define for our audience, whether they're listening or viewing, exactly what a hernia is?
Yeah, well, a hernia is a defect in some part of the abdominal wall, generally thought to be. There are some other places where you can have hernias, but the ones that we're talking about today happen within the abdominal wall and into the groin. The most common one is where there's a weak spot in the abdominal wall where the testicles descend in the groin. That's called an inguinal hernia. The inguinal region is a medical term for the groin. And probably the next most common site is at the belly button, and we call that an umbilical hernia. And then there's other areas anywhere in the abdominal wall where there's been an incision. We call that an incisional or ventral hernia. And then within the abdominal cavity, there's other places that the hernias can happen, and they're slightly more rare than the ones that you commonly fix along the abdominal wall.
Well, Dr. Stuntz, is it accurate to say that a hernia is sort of an abnormal hole or weakness or opening? Could we say that's fair?
Yes. A hernia occurs when one of those weak spots actually stretches out and becomes a hole. And so then the contents of the abdominal cavity can protrude through that hole. And what you feel as a bulge, that's the hernia and the abdominal contents coming through.
Okay, so that's very helpful. But before we go forward, hernias can occur in other parts of the body, right? There's a diaphragmatic hernia, there's a femoral hernia. I think actually at times we can talk about a muscle herniating, but mainly for today we're going to talk about the abdominal wall hernias, correct?
Sure.
And so we can say it's an abnormal weakness in a hole that may be enlarged.
Correct. Yeah.
So Dr. Stuntz, I recall actually in high school and actually at the Naval Academy, we used to call hernias like ruptures, and we thought maybe it was related to sexuality or infertility, and if somebody got a hernia, that means they were infertile or something sort of went wrong. Is that true?
No, that's a misconception. I think the term rupture comes in that sometimes a violent action or impact can cause the tearing that initially happens, but most commonly it's wear and tear over years or a congenital hole that's formed when you're born. There is no relationship to fertility. There is some relationship in that the holes in the inguinal region tend to come where the testicles descend, but the testicle has long since descended and made its trip, so there is no interference with fertility and function.
Okay, but Dr. Stuntz, isn't it true that women can also get hernias?
Sure.
And can't they get a hernia in the inguinal area or the groin area as well? Is that the round ligament?
Yes, yeah. Well, the round ligament is the analogous feature on a woman to the male's spermatic cord, or the cord that holds the testicle. And so that the same exact anatomy is there. It's just that a testicle never descends through it, so the wall is actually stronger in a woman in that location. But the weakness is there because the round ligament sits there. Yes.
Okay, so inside what most people call the stomach, but we're not talking about the gastric pouch, we're talking about the peritoneum, right?
Correct. The abdominal cavity.
The abdominal cavity. And inside the abdominal cavity is where we find the intestines, right, and the stomach itself and the liver, etc. And it's one of the jobs of the abdominal wall is to keep everything in place. Correct? And so when there's an abnormal hole or weakness in the abdominal wall, then something in the abdominal cavity can start to protrude.
Correct.
Isn't that correct?
Correct.
So, okay, so we've defined a hernia, and we know that some hernias are fixed and some hernias are not fixed or do not have to be fixed. So how do you decide, I guess for our audience, if they have a bulge or a hernia, how do they know if it needs to be fixed or not?
Yeah, I would say most of them do need to be fixed, but a lot of factors go into deciding who gets fixed. I think the older individual, somebody over 75 years or so, who has a small hernia and it's been present for a long time and safe, hasn't been growing in size, hasn't been giving them any symptoms, that's probably somebody that does not require the hernia to be repaired. Very commonly at the belly button, an umbilical hernia, I'll find that in somebody who's had it for 30 years and it hasn't changed much. So those sometimes can be safely observed. People with more serious medical conditions where surgery might be risky in them, those are people sometimes we'll just observe. But most of them do require repair because with time they can get incarcerated, or what can happen is contents from the abdomen can get stuck in that hernia and twist on themselves, and the blood supply can become compromised, and then it can be a dangerous situation and require an emergency repair. And
well, so I think that's important to talk about. So there can be a hernia, say at an early stage, when some of the abdominal contents might push through a little bit, but there can actually arise a situation where contents get stuck in there and may twist or may actually start to protrude, and that can lead to intestinal obstruction, which is an emergency.
yes,
right?
that's right.
So how does someone know if they have an intestinal obstruction? Is that something that they just know right away, or it's a real emergency and they can tell?
I would say most people will know because the site where the hernia is will be painful, and then they'll all have secondary symptoms of a bowel obstruction. They'll be vomiting, have nauseation, they will not be able to go to the bathroom normally, and they'll be sick. They'll start to get fevers and start to not be able to function.
Okay. So, and I also recall for some people that we fit them for a truss or some sort of support.
Yes.
For people who may not want a hernia repair or who may be ineligible for a hernia repair. Now, does a truss work, and is that really an effective treatment?
Well, it's mostly improves symptoms. In terms of long-term treatment for any kind of hernia, it's probably not the best idea. But it can help people, especially people you're not going to repair for a variety of reasons. What a truss does is it actually puts external pressure on the hole where the hernia is to prevent the contents from coming through. And they can be useful in certain patients until you get them to surgery. 100 years ago, it was very common for people to wear trusses because surgery wasn't available widely.
I see. Okay. And Dr. Stuntz, can't there be a congenital hernia? Like, can't babies have a hernia?
Yes, yes.
So how does that happen, that a baby would actually have a hernia or a weakening in the abdominal wall somewhere?
Yeah, well, it's most commonly where the testicle descends, and that in normal development, that area will seal up around the cord that persists. And in some babies, that doesn't persist, and so as you know, when they're a few months old to a few years old, that's discovered. Sometimes it's a small defect that, as childhood progresses, enlarges and becomes more obvious. Most cases present as young adults or on into adulthood as you get more wear and tear, and the pressure of the abdomen over time widens a small hole into a bigger one, and it becomes a symptomatic hernia, one they feel.
Okay. Now, Dr. Stuntz, as you know, and as most of my audience knows, I'm a plastic surgeon. I do a lot of abdominoplasty or tummy tucks, and I'm lucky to be able to work with you frequently, because sometimes in the office I'll see women after pregnancy or multiple pregnancies complain of a discomfort around the belly button or the umbilicus. And if we find an umbilical hernia, I'll usually call you or one of your colleagues to help me fix that in the operating room when we do the tummy tuck. Now, can we talk a little bit about the umbilical hernia or hernia around the belly button?
Yes. Well, those also tend to be somewhat dangerous because they're smaller holes, and things that get stuck through a smaller hole has more of a risk of twisting its blood supply and incarcerating and or strangulating. So those are the ones that I do like to fix. And when you're doing an abdominoplasty, as you know, the entire area is exposed. It's a perfect time to fix a small hernia in that location. Like we were talking at the beginning, some of those will never progress to any problem. So I'm not sure if you have to fix everyone, but when you're in that position where the cost to do so, so to speak, in terms of downside to the patient, is very low, you might as well fix it. So that's why we fix it. If I find one on a patient in general, if it's a big enough size, giving the patient significant symptoms, then I'll offer repair, and that repair is usually done with a mesh patch.
Okay, so that's where I'm hoping to learn a lot. You're going to teach me a lot in this segment, Dr. Stuntz. So I know there's different ways to do a hernia repair. There's the open approach. There's using a laparoscope, right, where you guys go in with sort of a little modified telescope. All surgeons in plastic surgery and in general surgery, abdominal surgery, we're trying to do more through smaller incisions, and oftentimes we'll use a laparoscope or an endoscope. You use them to do operations in the abdomen. I might do a part of a facelift or a forehead lift with them. So how is it that you decide if a person gets an open hernia repair or when you use the laparoscope? And I want to talk about a little bit of the mechanics of it. And I also want to learn more about this mesh that you mentioned.
Well, the type of repair depends upon a lot of things. Most is the location. So the inguinal hernias, I think there are two ways to fix it, basically, and you alluded to both of them. Either an open repair, where you make an incision directly above the hernia, go down, find the hole, and put a piece of plastic mesh underneath or over the hole, so you fix it that way. The other way is to come using a camera and go underneath that layer and put the patch underneath, so you fix it that way.
And is it actually plastic that you use, the mesh? Or?
It's polypropylene. It's a type of plastic, yes.
Now, and that can stay. It's not absorbable, and the body just tolerates it all right.
Yeah, I tell patients it lasts 10,000 years, so it'll be around for a while.
I see. So it doesn't just biodissolve.
No, no. They do make certain types of that in special situations, like if there's a severe infection and you're repairing an emergency hernia, you can use a type that will dissolve. But those are not good for long-term repair. They have a much higher chance of coming back.
So, Dr. Stuntz, in your office, in your practice, how do you counsel patients who are trying to decide between an open or an external repair or a laparoscopic repair with mesh? Like, how do you go through the pros and cons of that?
I have a discussion with every patient about that exact issue when you're talking about a groin hernia. And the issue is the inguinal hernia repair done open is our most secure repair. It has the least likely chance of coming back. The laparoscopic repair has the advantage of being the least painful, but has a slightly higher risk of the hernia recurring. And so most patients will have to make that decision. What is more important to them? A for sure long-term repair or minimal pain? And so we talk that out. And I think there are ways to make the open repair less painful. There are ways to make the laparoscopic repair more secure. So it's an individual talk you have with every patient.
Okay, Dr. Stuntz, that's very helpful. And in terms of the mechanics of the operation, do they stay overnight? Is it a general anesthetic? I recall that over the years, we sort of go back and forth. It seems like for a while we want to do every operation under general, and then it sort of becomes in vogue that we do operations under local with a little sedation, and then we kind of go back to general anesthesia. What's the sort of current practice? Is it inpatient? Do they stay overnight? Do they just have them on an outpatient basis? How's that work for hernia repairs? It's mostly done as an outpatient. It'd be a rare patient that would have a groin hernia repaired that way, and that'd be somebody who had a very bad heart or something like that. So we've got to be clear on that. So most hernia repairs these days are done as an outpatient. Correct. So that means it's in and out surgery. They come in early in the morning or in the morning. They have the surgery. They're observed for a little bit, right? And then they go home. Correct. Correct. And they get pain medicine at home, they take antibiotics. How's that work? Usually not antibiotics, but usually pain medicine is pretty helpful for a few days after a hernia repair. In a rare case, longer than that. I would say most patients have an outpatient experience if it's the groin hernia, and probably most patients have an inpatient experience if it's a larger hernia in other parts of the abdomen. Now, I recall, Dr. Stuntz, you know, it hasn't been that long since I did my general surgery residency. A few years. There's something called a Spigelian hernia, right? Isn't that right? Now, what's a Spigelian hernia? A Spigelian hernia will occur off the midline. So
The places we're most vulnerable for hernias to occur are in the center, the midline, where everything comes together. And in one area, it might not come completely together, and that'll turn into a hernia. And then in the groin region, where testicles descend, or where your esophagus comes through your diaphragm. Those are the areas that are most at risk. But you will occasionally see places on the abdominal wall that there are other hernias that occur that much more rarely. A Spigelian occurs on the edge, on the outside edge of the rectus abdominis muscle, the six-pack muscles that run in the center, the outside edge of that. And those are uncommon. I've seen probably 2 or 3 in my whole life. But they can occur there too.
They can occur. Now, another field or another reason why I'm lucky enough to be able to work with you when I do a tummy tuck or abdominoplasty is that sometimes they have women after multiple pregnancies or multiple operations, they'll have an incompetent abdominal wall or a ventral hernia or even an incisional hernia. So let's go through those if we can. Let's talk about a ventral hernia, and then if we have time, we'll talk about an incisional hernia. What do we mean by those?
Well, a ventral hernia means it occurs on the ventral surface of the abdomen, which is the front surface, the front in front of us. And ventral hernias typically occur in the midline, like I explained, but can occur elsewhere. An incisional hernia can occur anywhere ventrally, but where an incision is made, where they've gone in to take out your gallbladder, for instance, so a large incision along here, or your kidney on the flank, or in the middle, a C-section, for example, can cause hernias in those locations.
So an incisional hernia really results from an incision having been made in the abdominal wall somewhere or around the peritoneum that, of course, was strong at one time, but for some reason the surgeon had to get inside, and it could be months later or even years later where that area will become kind of weak. Isn't that right?
Yes.
So that's an incisional hernia.
Yes.
And that also can present as an emergency. Isn't that correct?
Yeah, those are probably the most common emergency ones, would either be the groin or an incisional hernia. And if it tears suddenly or a large portion of the bowel gets stuck in there, then that can be an emergency thing you have to fix right then and there. Most of them, the patient's aware of it, they come to their doctor, and we set them up for an elective repair.
Dr. Stuntz, we've only got a few more seconds, but I want to just ask you one more question. Now, with pregnancy, the entire abdominal wall, of course, seems to stretch out. Now, that doesn't guarantee a woman will have a hernia afterward, right?
No.
But some women do get hernias, but it doesn't guarantee she will have a hernia.
That's correct. And very commonly with pregnancy, a woman will see her umbilical area bulge out. And we don't fix those unless they fail to regress back to normal. And almost all of them do. It's an amazing thing about the human body, is that when the baby's gone and the abdominal wall comes back to normal, that hernia that was there will shrink up.
Well, Dr. Michael Stuntz, hernia expert, abdominal surgeon, general surgeon, we're lucky to have you on the Monterey Peninsula, and I'm so grateful you came on the program. Now, can we give out a phone number or a website if somebody has a question or wonders if they have a hernia or even wants to have a hernia repair?
Yeah.
So how do people get more information?
I'm in a group of surgeons, Monterey County Surgical Associates, and there are 7 of us, and our phone number is 649-0808, and you can reach us also on the web at montereysurgery.com.
You guys are so hip, digital friendly, right? Internet friendly. montereysurgery.com. Dr. Michael Stuntz, 649-0808, area code 831. Dr. Stuntz, thanks so much for being here.
Thank you.
I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health radio and television program. We're going to come right back after a very brief pause for a very good cause.